what is it? It's an 1814 waiver, which many of you may be familiar with, which actually allowed the state of Maryland to do something really innovative towards single payer healthcare, was in essence to create a single payer for all hospital care within Maryland. No states yet to replicate that. And then lastly is kind of my favorite, which is an 1115A waiver. And what an 1115A waiver is, and I think this creates the greatest opportunity for single payer healthcare, is it basically allows CMS to, through the Innovation Center, to allow states to do innovative healthcare within Medicare, Medicaid, and any federal program. So a really interesting opportunity there. With that said, let me talk just a little bit. Sam had asked me to talk about my experience with Medicaid waivers. And it really boils down to about 6 or 7 P's is how I sort of think about it. You know, the first P is policy. When I started in this business, I thought it was all about good policy. And if you had good policy, that was all you needed. Waivers would get approved. But it turns out there's a second P, which is probably the most important P because it's not all policy. It's a whole lot of politics. You've got to have reasonable policy, and policy needs to align with the federal government. You know, for example, it'd be unlikely for a state to get approval for an 1115 waiver to have work requirements in Medicaid with the current Democratic administration. That was actually possible within the Republican administration. So your policy needs to align with the policy and the politics of the federal government. But ultimately, waivers are really more about politics than they are about policy. To then have innovative policy, you have to think about politics writ large. You've got to have the support of not only, for instance, your congressional delegation and your state, but of a whole slew of advocacy groups. And those advocacy groups can help actually make policy. They can also hinder policy. I think John Santa was around when we had our first most famous waiver here in Oregon, the original Oregon Health Plan. You know, it took about 4 or 5 years for that to happen. And the reason it didn't happen right away was, interestingly enough, from a Democratic state, opposition from a Democratic president, Clinton, and mostly due to the opposition from Marian Edelman and Save the Children. So you've got to really think sort of carefully about politics. And it's important that when you think about waivers, that the politics and the policy sort of coincide, and that the policy needs to, one, be consistent with where the federal administration is going, because ultimately it's the Secretary of Health and Human Services that approves or denies waivers. So it's got to be consistent with where the administration goes. But you've also got to be concerned about the politics writ large. And if you really want to get innovative health policy done, that means you have to actually have not only the politics of elected officials aligning, your congressional delegation, but of things like unions, AARP, and others. Without that, it's sort of an uphill battle. So in terms of battles, that's the next P, which is pushback. What's been fascinating to me has been the pushback that you get around any sort of innovative policy. And that comes actually across the board. There are those who say, oh, you can't do that. that's the usual pushback, and that comes from both advocates who don't want something to happen. It also comes from within CMS, where there is always pushback, particularly from mid-level bureaucrats who tell you what can and can't happen. And that's a huge issue. Particularly the pushback you get from the external world. I mean, I hear that all the time. I mean, I hear that, quite frankly, from within the community in this room, where I think there's a good and a healthy debate about what's needed in terms of federal waivers to be able to implement a statewide universal healthcare plan. So that kind of leads me to the next P, which is persistence. The way you sort of get through that is actually persistence. Don't ever take you can't do that as an answer. I found that historically, I don't think I've ever seen a time and a place where that's true. I think, and this is kind of my final comment, but I'll get to that. It's worth reiterating, which is pretty much anything is possible if the politics align. This is waivers are 75, 80% political, and they're 25% policy. And when anybody tells you you can't do that, I would not take that as face value. We've been told, I've negotiated a bunch of different waivers where I was told we can't do that. And so you need to be persistent. And the persistence leads you to the next piece, P, which is about people. You need to have people, you need to have relationships with those within CMS, with the Secretary of Health and Human Services, with advocacy groups, because it's those people which will ultimately help you. When we negotiated our CCO waiver, we were told a lot of things right off the bat that can't happen, whether it was about global budgets, whether it was about getting the $1.5 billion, whether it was about all of that. And the reason that it happened wasn't because it was good policy. The reason it happened was because of politics. Had a governor who was persistent, who continued to advocate at the highest level, spoke every few weeks to the Secretary of Health and Human Services, spoke to the president. I talked probably every few days to the head of CMS and established a relationship and was able to work through things where, when someone says no, you can say, well, but here's what we want to achieve. How do we get there? And they can help you work with that. So a lot of this is about persistence. It's about people. Another P that you always hear is about precedent. The feds are always concerned that you're going to set some precedent that will, do something in other states that they don't like. So, when we wanted to have our global budget, the feds were really concerned about precedent. And they were concerned that the Mississippis and the Alabamas would use actually a global budget to throw people off of Medicaid as opposed to put people on. So precedent is something you've got to sort of think about and think through and be certain that it aligns. But, in the end, it's what I said. Waivers are political animals. They're really not about policy. I mean, we can sit here and talk about, I learned a long time ago, we can talk about all the benefits and all the great things it's going to do. It really doesn't matter unless the politics align. And unless you have the political support with waivers that, particularly around something as large and grand as we're talking about, which is, a single payer universal health care, you've got to have those politics lined up. Just talking about the savings and the great things that are going to happen, the policy isn't going to swing it. What's going to swing it is having 2 US senators on your side, having a president and a secretary of health and human services that wants to have it. But I think most importantly, it's about all of the people around the country that whisper in those people's ears. Advocates, unions, you name it, children's advocates, hospitals. I mean, now you can go through the list, but you've got to have the politics align. If you get the politics to align, waivers are really easy. Again, all waivers do is say states can waive some sort of federal requirement to do X, Y, Z. They're really quite simple. Where they get complicated is in the politics and within the winners and losers. So, with that, let me stop and love to hear any questions, comments, etc.
Bruce, I want to thank you for using, I think, my favorite word, persistence. And I want to thank you for persisting from that time we had the coffee and you said you would take this on, and you've been persisting and persistent. So thank you so much. Now I want to share a little bit of good news, which is timeliness. As you may know, California has passed their Senate Bill 770, which is a waivers bill. So we're going to have a big partner going forward in this waiver seeking world. I think that's, and maybe you could speak to that issue as you look forward to your next role, hopefully, and how that we might align the states. We have people from Washington here, and then California potentially taking the lead on this work.
Yeah, thanks, Tom. I mean, I think it's a great question. I think that, Representative Nose can comment on this later as well. I think that there's some great things about states aligning. And I think it's really great if you have California, Washington, and Oregon all align on a waiver and on policy. I think there's also some danger in that. And the danger is that, and I don't mean to cast bad notions on any state, but most states like to do things their own way. State legislatures like to put their own sort of stamp on things. And when you start getting multiple states in a room, you can spend actually a lot of precious time negotiating kind of minutia. So I think it's really important, and I think it's a really great thing. But I think you have to go into that with a little bit of caution to say, this is about the greater good, and it's about getting something done. And we can't get into this, well, we like 95% of this, but we need this 4 or 5% to go our way. It can be an impediment. And so really important, but I would say we need to be cautious about that. Yeah.
Thank you very much. This is great. What are the federal rules regarding where the request for a waiver has to originate? Does it have to originate in a legislative body or in a governor's office, or can it come from multiple places? And what are the rules about what we've heard is that the federal government would require a pretty detailed plan before it would even consider a request for a waiver. What are the rules about that as well?
Yeah, waivers actually need to originate from the state's executive branch. They need to come from a governor. Now, often, having said that, what the feds will do is the feds actually, and particularly in states where there's sort of a difference in political party between the governor and the legislature, the feds will often want to see legislative concurrence, but that's kind of at their discretion. Waivers need to originate from the from the executive branch in terms of the detail that's required, that gets at some of the politics. There's nothing written about the kind of detail that's required. It's discretionary, and that's where CMS bureaucrats have their sense of what sort of detail is required, and it's negotiable. They tend to require a fair amount of, I was looking for another P that hits, that was with BS. That's probably poop. But there's a lot of kind of administrative BS that goes into some of this. They're long documents. Most waivers are a couple hundred pages. They're mindful, they're mind numbing. Most of that is kind of required from the bureaucrats within CMS, but it's all negotiable. There's nowhere in federal statute that says here's what a waiver needs to contain. It's really all discretionary and up to the Secretary of Health and Human Services. And that's why politics are so important, because if the Secretary of Health and Human Services tells staff, this is what needs to happen and you need to do it, it'll happen. If the Secretary doesn't do that, it won't.
So the California waiver was from the legislature, but it went through the California governor's office?
I don't know that they passed legislation. They haven't submitted a waiver yet.
It just.
I believe what the California says is it's up to that the administration in California needs to submit a waiver.
Yeah, Bruce, historically, the Oregon Health Plan had 3 pieces of legislation that John Kitzhaber passed as Senate President. And the Democratic governor, I'm getting old, wonderful woman, Barbara Roberts.
Yes.
Barbara Roberts carried that from a waiver point of view, and Vicki Gates was our predecessor who did it. So it originated in the legislature.
It originates in the legislature, but it is the executive branch that actually has to apply. Sam, and then Mary Lou.
Mary Lou has been very.
No,
I don't want to cross Mary Lou.
I just wanted to say that when you talked about people and influencing, these various people, one of the things that I was told many years ago, I think it was either Brian Lashmet or Jack Dempsey, about nurses. And there are an awful lot of us out there, and every politician, every important person has an Aunt Mary who is a nurse. It could be your sister, it could be your mother, it could be your next door neighbor. And we got a lot of stuff passed by finding out who was the Aunt Mary to those legislators and getting that person to understand what we were talking about and convincing them. And so a very big piece of getting some prenatal money years ago with Frank Roberts was we found out that an OHSU faculty person, nurse, lived next door to Frank. And over the back fence, she talked to Frank about how this was so important. And she was an adult nurse. She knew nothing about prenatal business, but we convinced her and she talked and we got the money. So I just kind of keep thinking about who's got an Aunt Mary that's a nurse that we can work on.
Just for the record, Mary Lou is my Aunt Mary. Always has been, always will be.
Good team.
Sam.
Thank you. Of the political piece, it sounds like there's both mobilizing state politics, but there's also national politics. Can you compare the difficulty and import of those two?
No, great distinction, Sam. And I think actually they're both equally important. You've got to have, particularly if you're going to ask, so let's first take state politics. If you're going to ask the federal government for something really substantial, the federal government, the Secretary of HHS, the president, they're not likely to be very supportive of something which is usually divisive in a state. They're going to want to see a fair amount of political congruence. Everybody understands you never get that 100%, but you know, they're going to want to see the alignment of the politics within a state that are consistent with who they are. And then you're going to want to see the same congruence at a federal level with, now obviously here in Oregon, we're not going to have a federal delegation that's going to be 100%. There's always going to be potentially one or two naysayers within our delegation, in our congressional delegation. That's okay. I mean, you don't have to have all of that, but I think it comes down to, the congruence of, again, legislatures, advocacy groups, et cetera, writ large. You've got to align it at both levels. And I think really important to have that happen. And the organizing, I think, first has to come actually at the state level and begin to bubble up, because all politics is local. And that's where I think the work needs to get done. And when you have a really strong and forceful advocacy from a governor, from a legislature, from advocacy groups within a state saying this is the way we want to go. I mean, John, isn't that how we got the Oregon Health Plan initially passed? Was, I think, because of that really strong advocacy. Coming back to the original Oregon Health Plan, it all was about Oregon health decisions and 10, 12 community meetings around the state, where Oregonians, whether it be in Pendleton or in Portland, said, we really support having universal health care here in the state. And I think that congruence of politics is what ultimately sort of helped us, but we had to be really persistent. Sorry, long answer. Yes.
Hi, recently, Ro Khanna from California introduced the state-based Universal Healthcare Act, or SABUCA. And of course, it's a Democratic thing in a barely Republican House of Representatives. But what do you think would be the effect of it? What do you think are its chances of passing?
So I think it'd be fantastic. And I think, this is where, it's an interesting discussion within the single payer advocacy community about whether we need national legislation or whether you can do things with a waiver. I'm of the camp that says waivers are all political. You can get anything done with a waiver if the politics align. So I'm not sure you actually need federal legislation. Having said that, boy, if you had federal legislation, that'd be just fantastic. It would cut through a whole lot of this. So I think having federal legislation would be great. I think we should all push for that. I'm not so sure in the current, I'm no expert on the politics of DC, but my sense is unlikely to happen in the current House of Representatives. But again, persistence is really important, and we'll get there someday. That body will change.
Following up on what Sherry just mentioned, one of the key aspects of creating a state single payer system is to take, for example, all Medicaid money, put it into a single pool, and then spend it for healthcare of people who aren't on Medicaid. One of the headbanging discussions that we have is there something in the Medicaid legislation itself, 1965, whatever, that would forbid that? That is, the state applies and says, can we take Medicare money and spend it on the wealthy, because we're going to be including everybody, or can we weasel our way through that? Do you have any sense of how that might work.
So it's a really good question, Sam, and I mean, I think that that's been, obviously the to have a waiver that basically says, we're gonna meld all these different funding sources and pay. I guess I would look at it differently. It's really about how we would use multiple sources to pay for healthcare for everybody, not necessarily to take Medicaid money and spend it on the wealthy. I don't think there's anything that specifically prohibits that in legislation. I would look to Hayden and other legal scholars in the room who could sort of look at that. But historically, what CMS has been most concerned about is the use of federal dollars and that being used appropriately towards Medicaid. There's a wiggle room line there about, what does it mean to actually do that? And if you could maintain the same benefit and the same quality, that's really what the feds have been most concerned about. But it's a great question. Yeah.
Yeah, I want to challenge that. Nice watching.
Get the mic so that you're on record.
I like to challenge it, but my name's Roger Gantz, after Fort Washington. My former life was a Medicaid policy director of the state of Washington. And like yourself, we had an opportunity to go through these 1115 waiver process. So one of the things, 1115 small a is not the 1115 big A, that's a different pathway. I'm trying to do that. But in that, CMS, Healthcare Authority, historically, prescribed to parameters called budget neutrality. And that has been a consistent parameter. What essentially that says is, we'll grant you waivers to do a lot of creative things, but so long as you would spend no more in federal dollars than you would otherwise absently.
Right.
So the notion of saying, well, we're gonna take these dollars and expand on that, you can't meet those budget neutrality parameters. And I will say that parameter, which you know, I do, has been consistent with 1115 waivers from the get-go. That's not a DR one, in my opinion. Can I pick up?
Yeah, it's interesting. I mean,
Mike. One of the things, in part of my work, I'm on something called, the Finance Technical Advisory Committee, FTAC, for our Universal Healthcare Commission in the state of Washington. And we're struggling along at a slow pace, but the pace it is. One of the things that, Healthcare for All Washington is trying to share with that austere body is a notion of incrementally growing the ability towards a single payer system. So I'm speaking for myself, not for my organization, but I believe, and I'll get to the point of this point, there's a pathway towards that. And that pathway to me is bringing together those aspects that the state itself now purchases healthcare. And I'll speak this for Washington. That's about 1/3 of all insured people in the state of Washington are either through Medicaid or our exchange or public employees or school district employees. To bring that together as a building block towards a single payer system. Now, my point about all that, and I'll finish here. I strongly do believe everything you're saying needs to be, those P's need to be in place, but there is a pathway for Medicaid. I do not believe there is for Medicare at this time, but there's clearly one for Medicaid. And that's 2.1 million people in Washington to begin to build that system. So,
Thank you, Roger.
Thank you.
Yeah, budget neutrality is one of those great things. There's probably only one of us in the room, which is Roger, who understands budget neutrality. I never have. Although what I've totally understood, I mean, what I've learned in negotiating with the feds, yes, states have to have budget neutrality. Having said that, there's it's like Swiss cheese, and you can define budget neutrality in a variety of ways. The feds say you can't carry money forward. We've carried money forward since 1989. And so it's an interesting discussion. Hayden.
Yeah,
Yeah, just to respond briefly on Sam's good question. I think we already have examples of this. So we've got Maryland's waiver, which combines Medicaid funding with all other lines of funding. We also have the PACE program, which does the same thing between Medicare and Medicaid. And any system, any single payer system we would have would be a redistribution of funding on aggregate to Medicaid rather than away from Medicaid, because Medicaid's the program that's funded the least. So my sense on that question is that wouldn't necessarily be a constraint. And I would further underline Bruce's point on CMMI authority. The statutory authority for CMMI is incredibly broad. So this just gets back to the point of whether there's the political will in an administration to do something like this.
Yeah, I mean, the 1115A waiver basically clearly states Medicare, Medicaid, and states' ability to be innovative as so long as they continue with the same benefits, et cetera. So I think there's a real opportunity with those innovation waivers. I think there's incredible amount of flexibility because it's really ill-defined in statute.
Thank you, Bruce. We have time for one more question, which Alex is going to get. Did want to mention in terms of budget neutrality that when Bruce and our governor walked away from Washington with a waiver, they didn't just get a waiver, they got $1.5 billion in credit. Now, that is pretty astounding. If we could do that just 10 times a year, we could.
But Sam, that happened because of persistence and politics, and the final decision maker on that was President Obama, who, I mean, we were told multiple times, in fact, just to give you a little history about that, we went to meet with CMS and White House staff, and the governor had gotten a call from Secretary Sebelius that morning, in essence, giving him a heads up that we were walking into a meeting where we were going to get a no. And, John Kitzhaber was just persistent, worked the political lines to the White House. And we sat in this meeting with Cindy Mann and a bunch of other folks. And the conversation was a little awkward because it was sort of circular. And in walked the president's deputy chief of staff, who whispered something in Cindy Mann's ear. And next thing we knew, they said, we've got an agreement. And I just say that because it's really all about the politics and the personalities and the people and the persistence. That's how it happens.
Bruce, I just can't resist. I mean, I was involved in a similar meeting during Governor Kitzhaber's second term. And when we walked into the meeting, there was Marion Edelman.
Yeah.
And it was clear we were going to have to convince Marion Edelman. She was the decision maker, and she deserved to be. And frankly, she was right. The version of the Oregon Health Plan that we were talking about was discriminatory, and she carried the day.
Thanks, Bruce. Just a quick question. So you kind of implied that it's always a top-down procedure. You gotta have the president and the HHS secretary on board, and then all the mid-level bureaucrats are just they're just stopping. Is there ever any reverse action? Like, can you get champions in the administration on something below the lower level and kind of push from underneath? Has there been any record of that at all?
I guess let me clarify what I said, which is, Alex, one, I think, yeah, you can do that. I think, however, for something as large as a state single payer, it needs to sort of permeate throughout. It's got to come from the bottom up and the top down. A lot of waivers and policy never sees the white of the eyes of the Secretary of Health and Human Services or the President, et cetera, because it's very technical, things that they're not gonna, that aren't huge health policy that's gonna create a precedent. That kind of stuff happens at the staff level all the time. But if you're gonna have something that big, it's gotta come from all levels, but particularly from, not that it has to come from the top down, but that you've gotta assume that decisions are gonna be made at those levels.
Thank you very much, Bruce.
My
Much
pleasure.
appreciated.